Good day, everyone, and a warm welcome to the fifth edition of the MNCH Expert Dialogue Series, hosted by the Foresight Institute of Research and Translation, FIRAT. Today's theme is Bridging the Gap, Elevating Mothers' Voices for Better Healthcare. This dialogue is dedicated to highlighting the critical importance of listening to and learning from mothers' lived experiences in shaping stronger, more responsive healthcare systems. We are honored to have two special guests with us: Dr. Cornelia Ochola, pediatrician, global health specialist, and MNCH expert. Dr. Ochola brings 15 years of experience spanning maternal, newborn and child health, immunization, and health system strengthening across low and middle income countries. She has served in leadership and advisory roles with USAID, ministries of health, NGOs, and social enterprises, designing impactful programs that advance maternal and child survival. Beyond her policy and program work, she is also a digital health communicator, leading campaigns to end preventable MNCH deaths and amplify evidence-based, scalable solutions. Mrs. Laju Edwards, a mother of two and the CEO of Pi K Accessories. Mrs. Edwards joins us to share her lived perspective as a mother, offering personal insights on the realities of navigating maternal and child health services. Her voice reminds us that beyond data and policy, the stories of mothers themselves are vital to building more equitable and effective healthcare systems. With such a blend of professional expertise and lived experience, today's conversation promises to be deeply enriching and thought-provoking. To officially open and guide our discussion, it is now my pleasure to introduce our moderator, Dr. Bisola Olubiyi, medical doctor, clinical researcher, and MNCH program coordinator at FIRAT. Dr. Bisola, the floor is yours.
Hello, everyone. Good morning, good afternoon, good evening from wherever you're joining us from. I think we'll just wait a few minutes to allow people join us as well as the panelists, the guests. So we'll start off by 11:05. Hello, Mrs. Laju Edwards. Thank
Mm,
you for joining.
sorry, I was having network.
No worries at all. Hope you're doing well. Can you hear
Can you
me?
hear me?
Yes. I said I hope you're doing well.
Yes, I am. Doing very well, thank you.
Thank you for joining us this morning. We're just waiting for a few minutes to allow the second guest join the call. So in maybe 2 minutes we'll start. All right,
All
thank you.
right.
Okay, I think we're just going to dive in and hopefully Dr. Ochola will join us while we are still in the early phase. So, thank you once again for joining this episode of the dialogue. I know we're still few online. Hopefully, people will join later. But this is a recorded session, so people who are not able to join live will be able to watch it later on YouTube. So, so thank you once again for joining. I can see Miss Rakia Ahmed. Thank you for joining. So today is a very important one and one that um, I hold so dear to my heart because we are not just speaking to experts like we've been doing. Today, we are speaking with someone who has had the experience. We are speaking with somebody who has had a frontline experience. And so um, I'm saying hello to everyone once again. This is the fifth MNCH dialogue series, and it's hosted by the Academy under the Training, Education and Development Division of FIRAT. And today's theme is Bridging the Gap, Elevating Mothers' Voices for Better Healthcare. And it couldn't be more timely or more important because for too long, the voices of mothers who are the very individuals at the heart of maternal, newborn, and child health has always, often been overlooked in the design and delivery of healthcare services. Most times we just maybe go to the field and do research and then, make policies. And that's in the best case. Many times policies are even passed without asking people who are affected how they want something to be done for them. So it's very important that we hear the perspectives of those who have had this lived experience. And that is the key to building a responsive and effective um, response or healthcare system that works for mothers. So this session is about listening to mothers, shining a spotlight on the realities faced by them, and creating a platform where their insights can help drive the transformation of healthcare from policy right down to the point of care. So today we are to have distinguished guest speakers who bring expertise, experience, and passion to this dialogue. So I encourage us to listen, to reflect, and to contribute. We are very open to contributions so that together we can bridge the gap and pave the way for healthcare that truly matters for mothers and children. So, with that, let's begin today's dialogue. Our guest today is Mrs. Laju Edwards. She's a dynamic entrepreneur and a proud mother of two, bringing a lived maternal experience to share with us today. She's the CEO of PK Accessories, a thriving fashion brand located in Abuja, Nigeria, specializing in the wholesale and retail of unique, stylish, and affordable accessories. And beyond her role as a business leader, she embodies the voice of everyday mothers, navigating the balance between family, work, and community life. So her perspective is especially valuable in today's dialogue as it highlights the realities of mothers as somebody who has, used healthcare from let me know, just she would share with us, and while also contributing economically and socially and facing the challenges of accessing and advocating for quality healthcare for herself, for her children. So she joins us today to share insights that bridge personal experience and practical advocacy, reminding us why elevating mothers' voices is essential for achieving better maternal, newborn, and child health outcomes. So, with that, a round of applause and welcome to Mrs. Laju Edwards. Thank you for joining us. Our second speaker, we are still waiting on her. I believe she should be joining us soon. Is Dr. Cornelia Ochola. She's a pediatrician, a global health specialist, and a maternal, neonatal, and child health expert. She's a pediatrician and global health specialist with 15 years of experience in maternal, newborn, and child health, immunization, and health system strengthening across low and middle income countries. She has held leadership and advisory roles with USAID, the Ministry of Health, NGOs, social enterprises, designing and leading high impact programs that advance maternal and child survival and health equity. Our work integrates policy advocacy, program design, community engagement, supporting organizations to scale innovative, evidence based solutions that strengthen and empower communities. She's also a digital health communicator, leading a year long campaign on ending preventable maternal, neonatal, and child deaths and championing scalable solutions that transform maternal and child health outcomes. So, with that, I welcome Dr. Ochola. She's not here yet, but I believe she'll join us soon. So, Mrs. Laju Edwards, do you have any opening remarks before we dive into the questions? Mrs. Laju Edwards? Sorry, you're muted. I can't hear you. Do you have some opening remarks, please?
Oh, thank you so much for having me. I really appreciate it, and share my views as well. Thank you.
Sorry, I didn't hear you clearly.
Hello, can you hear me now?
Yes, it's better now.
I was saying thank you for having me. Thank you for the opportunity to share my bit on my experiences so far. I'm so excited to be here. And I'm hoping to learn from this discourse as well. Thank
Thank
you.
you so much. So I would ask you the first question. Can you share with us a bit of your experience as a mother? For me, for instance, by virtue of my training, I've, been around the healthcare sector for a while, but to be a user of, maternal and child healthcare services was when I got married and got pregnant for the first time, and the experience is something else. So would you like to share with us your memory of your first experience with the healthcare system as a mother, maybe when you were pregnant, or when you wanted to deliver, or when you had your child? Can you share with us, please?
Okay, my first experiences will date back as well for me to my first pregnancy as well. So those were the first memories that I think I can relive. Being pregnant for the first time, visiting the gynecologist and having access to the much that I could at that time. Well, because I didn't quite have a pleasant first pregnancy experience, I had to visit the hospital a little more frequently than everyone else at the time. So I think I was there every week. And I don't think it was quite pleasant for me, in all honesty. I don't think it was quite a pleasant experience for me, although I later got to have access to a more personalized care routine. Can you hear me? Yeah,
Yes,
so
please go ahead.
so in the first few weeks of my pregnancy, I didn't quite have a pleasant experience, but I later had access to something that was personalized and better suited for my peculiar journey. Yeah, so I think I've had a bit of both worlds. Yeah. Are you there? Hello?
Sorry. Please, I'm with you.
Okay, yeah, so that just summarizes. I've had a taste of both the good and the bad so far in my journey.
Please, can you expatiate on why it was unpleasant? You mentioned that it was quite unpleasant for you. Is it by virtue of your own health condition, or how you were treated, like your experience at the healthcare facility?
Okay, so I think yes, my the condition that I had at the time also influenced what's the experiences that I had, because for instance, like I said, I had to show up at the hospital every week. And quite early in my pregnancy, I was dealing with the case of a fibroid. So so quite early in my pregnancy, I was um, I was sickly, and I had a lot of complications that I couldn't really understand at the time because it was my first time as well. And so I had a protruded tummy quite early. At 3 months, I was already looking like very big. And so I was dealing with a lot of issues that I didn't understand. And I felt like I wasn't getting the care that was commensurate with what I was going through at the time, because I needed a lot of explanations. I needed and then a lot of explanations. And then I was experiencing issues that were different from what people who were at that trimester was experiencing. And I wasn't getting I wasn't being treated, especially, I would say, at the hospital that I was using initially, because it just felt like, oh, everybody was getting this XYZ amount of care. And it was this XYZ amount of care that I was also being exposed to, whilst I had other issues that needed more attention. I don't know if you understand what I'm saying. Yeah, so that was the struggle that I had. For instance, I'm showing up every week at the hospital, and there really isn't any explanation as to why I have to show up every week, apart from come next week, come next week. There really isn't so much explanation as to, oh, you have to come every week so that we can maybe monitor, like I said, monitor the growth of your baby, or, just, it wasn't, those first few weeks were not really pleasant for me, in all honesty. Yeah, until like I said, I later got better care somewhere else. So I would say that I had So I was able to tell that what I was getting before wasn't quite what I should be um, offered. I don't even understand what I'm trying to explain.
Hmm. Thank you for sharing that. If I understand you correctly, I think two things stand out for me. The first is that the healthcare professionals that were in charge of your care did not
Yeah,
offer enough explanation concerning your condition. Is that right?
yes.
And also, would you say that the care was not as compassionate as you would have loved it to be?
Clearly, it wasn't as compassionate as I would have loved it to be at all. And for the most part, it also felt like I was a, I don't know the actual word to use, but I felt like I was some sort of experiment. So
Wow.
that's, yeah, so that feeling also made me dread going there. But I had to show up anyway. But every time I would, because I remember I had this experience where, um, I was having contractions as early as 9 weeks,
Wow.
and you can imagine someone who has never been pregnant. So I really didn't even know that they were the kind of contractions that would come at the last trimester of pregnancy. You understand? So I
Mm-hmm.
naturally would have thought that maybe happened to maybe a good percentage of pregnant women. And then I go there and they're like, contractions at 9 weeks. And it just felt like they were disrupting my, I would have wanted some sort of privacy, but I wasn't getting that. And then I just had a group of doctors. I remember that I just had a group of doctors come around me, and then they're like, what's wrong with her? It was this open consultation, which I didn't quite have a problem with if I was still treated with some sort of care, or some sort of pride, because I'm a very private person. So and they're like,
Hmm.
she's having contractions. She's having contractions at 7 weeks. What's the problem? And it felt like I was talking. It felt like 10 or 11 doctors were talking to me at the same time, and I was
Wow.
confused. I was quite confused about what I was dealing with. And then this one is asking me, so what's wrong with her? Oh, what's happening? And then I started hearing all sorts of medical terms. I just felt thrown back, confused, and wondering what's going on. So
Wow.
in those first weeks, honestly, I dreaded going to the hospital. I dreaded, this routine antenatal exercises when you go to the hospital and then like everybody should stand up, everybody should sit
Yeah.
down. Couldn't stand, I couldn't sit, I wasn't in the mood for because I usually would be in so much pain. And
Wow.
everybody really saying, oh, this is a special case. Can you sit back? You don't really have to do what everyone else is doing. It was just this general, I felt like I could have gotten better and private or a more personalized care for
Hmm.
me. Yes, that's
Okay,
what.
so I'm going to play a bit of a devil's advocate based on what you have said. So is this thing peculiar just to doctors or also nurses as well?
Frankly, quite frankly, I think it wasn't peculiar to doctors. It was both doctors and the nurses. Because if you know the Nigerian system very well, it's even the nurses that you get to encounter first. They do the most of the antenatal care and routine, maybe until you now have that short time visit with your doctor. So I think it's not peculiar at all. It's both. There's not that sensitivity that comes into play where, you walk into a place and you just expect that these people are better experienced. Sometimes I don't know if you felt like I was asking for too much, but I feel like if you ask everybody to stand up and you notice a particular patient struggling to stand up, there would have been times why are you struggling? Is it that you can't stand up? What's wrong with that person? Not just say, stand up, everybody stand up. Pregnancy is not, just general assumption of everybody here.
Hmm.
these little exercises. Do you get where I'm coming from?
These are some very I would say I don't want to say damning allegations as it were. But I hear you what you are saying, that there's that general lack of compassion that you felt regarding the healthcare experience. The fact that the doctors will be talking over your head like they're discussing your case among themselves, instead of that having that patient-centered engagement, as it were. And also the nurses that would see you struggling to stand up, sit down, and then they could have been more compassionate to say, madam, please don't worry, you don't have to sit, you don't have to stand, just be in a comfortable position, that kind of thing. It's really important that at this point we hear from healthcare professionals. Unfortunately, Dr. Ochola is still not with us, but I have two senior nurses on this call, and I would be asking them to weigh in on the things that you have talked about. I would ask, first of all, Nurse Maria Korede and Yolorunda, can you, as I would say, an ad hoc representative of nurses, can you weigh in on some of these things? I know that many people say some nurses can be, very, and we've had this discussion and conversation among ourselves in previous episodes where we say some nurses, maybe because of having seen, and there's some degree of maybe hardening your heart when you're in the health professional, so they tend to be on unempathetic to the plight of patients, something like that. So can you please weigh in on what Mrs. Lajue Edwards has discussed, Nurse Maria? Thank you so much for joining us. Sorry, you're muted. We can't hear you.
Okay. Is this better for you? And I hope I'm
Yes,
clear.
yes, you
I
are.
do apologize for my sound, location, and everything.
No, it's
Yeah,
okay.
I need to say that first. But I think in general in healthcare, if I start off with a bit of background, so I trained in Nigeria as a nurse, a midwife, and a public health nurse. It was a package that my university made us do back then. And, in hindsight, it was like, okay, they were trying to make us fully equipped, white, well exposed to whatever it is that the world does bring. And many years down the line now, realizing that, oh, actually, even though it was stressful at the time, it came in handy. I say all of that to say that some things we experienced during all of those periods of exposure, like to clinical practice in within Nigeria, s- some of them kind of like built us a sort of foundation that you may or may not appreciate depending on the situation that you know that you're in. Now, completing my education in my institution and then starting off a job with professionals who came in from America to set up a practice. And they had been practicing in America for like 17, 18 years as pediatricians. Eh, And when when you start to see the way they were practicing, you need to learn, unlearn some things. I don't know if that makes sense to a lot of you.
Yeah.
And when you start to see how not to behave and how to behave, I hope that makes sense.
Mm-hmm.
And then when you're like, oh, actually, I need to revamp my entire knowledge base and how I should interact with professionals. So I started to now have a bit of a patient focus approach in my nursing practice, let me put it that way. Not like previously, I wasn't taught the patient focus, but also I'd experienced working in environments where the patient is practically lying to you. A child comes in convulsing and all that, and then you say, "Oh, it just started today. The child only just became unwell today."
Yeah.
there's that distrust for patients giving history. And then there's also not being able to, when they start on that footing, your level of empathy, compassion, you're like, if you're going to watch a human being in this state and you were going to carry on in the way that you were doing, like, I'm not, you start to speak a bit brashly, even when you don't really want to. It's a bit unfortunate, but also when I then move into a climb where, quote unquote, saner climbs, where you're now told the patient is king, really. And even if you can see through your eyes, through their nose, that they're lying to you, you're still going to approach them with the best of intentions and recommend to them what you would um recommend for them to do, agreeing to yourself or not. But also now, in my current practice, because I've kind of like moved a little bit within my practice, I've moved into a state where you say I'm doing things autonomously. So I'm having to assess people's capacity for judgment. So if I think this person is not doing things appropriately, are they in their right mind to be able to make this decision? And then if I don't think that they are, I can start to think of legal grounds to be able to implement healthcare even against their wishes. I hope that makes sense. So, I'm
I'm
trying to
sorry,
explain a
I
few
lost
because
sound a
I
bit.
oh my days, oh my days. Can everyone still hear me? Please, if you
I
can,
can
just
hear you
a few
now.
thumbs up would be helpful. Okay. Oh days. Okay. Um, is and yeah, okay, great. Fine. Okay. So you can hear me. Okay, so I think what I'm trying to explain is there are some legal frameworks that don't even allow you to be able to treat the patient in certain ways, even if you feel like doing so, even if you think you're not, because already as a practitioner, there's that there's that hierarchy that you hold where somebody's health is in your hands. I
Hmm.
don't, and you now need to make the patient see that all that I am doing is in your best interest, even though you're seeing me as quote unquote Lord and Master of your healthcare right now. I am still doing things in your best interest, but also patient-centered. Come to the level of the patients to ask, does this work for you? Because if a patient says they can't get up from a chair, they actually cannot get up from a chair. And pain is whatever the
Yeah,
patient calls it. If they say my patient
exactly.
is 9.5 out of 10, you can't minimize their pain. So even if you think that they are lying, you must still treat based on the information they have given you, and then also administer medication based on what they have told you is their symptom. So I think
Oh Lord. No, Scoride. Sorry, I
I
can't
think I
hear
lost
you.
you. Okay, uh,
Hello, sorry, can't hear you. I don't know if it's mine. Okay. I'm sorry, I can't hear her anymore. Um, okay. Mrs. Binuyo, are you there? Can you please weigh in on what Mrs. Laju Edwards has shared? Mrs. Binuyo has been she has been a guest in a previous episode of this dialogue series, and she's also a healthcare professional from Nigeria who has a wealth of experience, especially maternal, neonatal, and child health. So, Mrs. Binuyo, can you please weigh in on what Mrs. Large Redwoods has shared?
If you can hear me.
Yes, we can hear
Hello.
you. Hello,
Yeah.
Ma. We
Good
can
morning.
hear you.
Okay. Actually, I want to start from where a colleague of mine stopped. As a good practitioner and as a good health practitioner, and you really have the passion for your job, you should be in two centers. The first thing is you have to look after your patients, your achievements, and the objective on that patient really matters a lot. And when patients are in pain, they don't actually look into that perspective that you are looking at their own interest or you want to achieve a better thing for them. They want to get out of the pain first. At the same time, they want you to treat them well too. The third aspect, they want themselves to be out of the hospital. And to achieve that as a nurse or a midwife, I think in the best interest is to let your patients know the reason why you are doing what you want to do. I think where most of us are getting it wrong is not carrying the patient along. That this is actually what I want to do for you. This is in the best interest of yours. By the time I finish this, you will be okay, and this and this. So, in lieu of that, patients get it very wrong. Now, look at how she's shouting on me at that particular time. Imagine a woman in labor, and you have been sympathized with somebody who's supposed to give episiotomy to. Don't you think the woman is in danger, and at the same time the baby is in danger? So at that particular time, you cannot be friend with the patient. The only thing you can do is to let your patient know that this is actually what is going to happen. Madam, this is the situation at which we are now. So please, can you please cooperate with us? We are going to give you this. So even in the profession and with the legal backing, your patient, you have to seek the consent of your patient. Secondly, at that particular time, you are not a friend to your patient. But you have to carry the patient along. And when you look at the attitude of some patients too, at that particular time when it's called for urgency, you cannot romance them. You just have to be frank with them. So I think this is where most of the patients get it very wrong. Or let me say clients get it very wrong. That these health workers, they are not good, they are not doing this, they are not doing that. So I disagree with that aspect. Secondly, is if an health worker is overwhelmed with work. Taking for instance in Nigeria, you can see the way at which our antenatal are, especially some that works in the state hospitals. You see that, or in northern parts of the country, you see the way they give birth there. When you have a lot of people in labor ward, you are to attend to them, and mainly the numbers of of midwives on duty, and you are to attend to a lot of things. So it will get to a stage whereby such kind of midwife will be overwhelmed with work. And so when a patient is not cooperating at that particular time, we will tend to shout. I've even shouted once, Madam, you just have to cooperate. This is between life and death. So please cooperate with us. Do you understand what I'm saying? So I cannot say those issues are not going on, but not to the extent of at least now losing their respect or their integrity. No, you still have to carry your patients along. So, and at the same time, the third point I want to mention is that, people go into job whereby they don't really have passion for it. They just find themselves into it. So those aspects will contribute. So I cannot say that those things are not happening. They are. But if truly the numbers of people that really have passion for that job, and when we take it into consideration, okay, health practitioner, we cannot generalize it, because even legally, you have to have an empathy for your patients. So those are the aspects I want to talk about. Thank you.
Thank you so much, Mrs. Binuyo, and thank you so much, Nurse Maria. Sorry we lost audio of the later part of your contribution, but I think I can weave both together. I think Nurse Maria was saying that she trained in Nigeria, and then when she moved to the UK to practice, she saw another aspect of practice and how you have to be, respectful, and how there are legal frameworks that you must follow in giving care to patients. But Mrs. Biddy, on the other hand, says, yes, you have to be respectful, but sometimes patients
Yeah.
don't want to be cooperative. So
Mhm.
you have to find a way to be firm while delivering the quality of care that you have to deliver. I think at this point, I will just say something. There's this thing that when you're trying, there's this scale, Glasgow coma scale, like when you're trying to examine a patient to examine or gauge their level of consciousness. So in Nigeria, there's this thing that we do. You use like your knuckle to rub the person's sternum very hard and see if the person will cry, like, hey, egg me or
Right. Yeah.
something. So somebody that is a colleague of mine moved to the UK and then did the same. And I think they said they had to call a
Mhm.
panel that, do you want to kill the patient? What are you doing? That you just, you have to rub gently on the sternum. And for us, it's different. Like you rub the sternum very well. And then when you're doing this patellar reflexes, there's this thing you do when you use the armor that you don't do it like that. You want to hurt the patient,
Yeah.
It's like the practice
Mhm.
is so different.
Yeah.
But the thing is, regardless of the climb, it's very important to practice respectful maternal care. So at this point, I will turn it over to Dr. Cornelia, who is now on the call. Hello, Dr. Cornelia. Nice to have you this morning. Thank you for joining us. I understand you're very busy, but thank you for joining. And please, can you weigh in on all the discussions that we've been having so far?
Good morning, everyone, and thank you so much. My sincere apologies for logging in late, but I'm
No
really
worries.
excited to be here and just listening into what the conversation has been so far. It's quite enlightening. Just weighing in into this particular topic. I'm sorry I'm not putting my video on because of the move. I'm actually taking the call from the cows, texting to somebody, and I just realized it's midday. I had to come out. So I hear both perspectives, and I respectfully hear both where we are coming from. And really sorry for what happened to our dear lady in the hospital. When we come into our setup, these are some of the things. Normally, when there is disrespect and lack of dignity within the health facility, these are some of the things that send women away. And what we are looking towards is increasing access, meaning having the hospital to be a place where women feel they can come to hospital and deliver and they'll be treated well. I can give examples of stories I've heard even in the country I'm from, in Kenya, where a mom is even slapped that, this baby needs to come out now, or why are you doing this, and the baby needs to be delivered. And thereafter, the mom never comes back and delivers in the same hospital again, and they end up going to traditional birth attendants for delivery. And we know the complications that happen with that. And so WHO has come up with what we call respectful maternity care. I'm not sure if it's already in Nigeria, but in Kenya, that guideline has already been set up. And what it does, it really looks at the right of every woman to receive dignified, compassionate, non-abusive care during the entire pregnancy period. So whether it is in the clinic, during the time for labor and delivery, and even during postnatal clinic and the baby child welfare clinic as the child is getting growth monitoring and immunizations. Just ensure that this is grounded within human rights, ethics, and professional standards. And the core principles for this really looks at treating dignity and respect. And this looks at treating women as individuals, valuing their choices, and really looking at it also from a cultural perspective and just understanding how different cultures are. How you'd, just from what Dr. Bisola has shared, sometimes how you'd approach a mother in the UK and how you'd approach a mother in certain parts of Africa would not be the same, because in certain areas they pick that as disrespect. The other thing is privacy and confidentiality. I've been to hospitals and you hear the nurse saying, the mother who was bleeding, yes, you come here. That already you've shared someone's personal information, or the healthcare worker has shared someone's personal information with an entire group who did not need to know about her. The other area that it looks at is informed choice and autonomy, meaning giving health education. And during antenatal clinic, during labor and delivery, and also during postnatal, there's a lot of health education that happens in our healthcare facilities so that the mothers are able to have an informed choice and make choices that they understand why they're making them. The other thing is looking at freedom from abuse. So protecting women from verbal, physical, and emotional mistreatment, neglect, and even discrimination that we have seen. There are certain parts of Africa and also in my country where there are women who get female genital mutilation. And when they come, once that is seen, there's some form of discrimination, or even some mistreatment, wondering how. But this was done culturally. And so instead of going back and saying, okay, understanding where this came from and seeing how to change the behavior of the community in that area, some of them really undergo different forms of mistreatment within the healthcare facility. So being able to support the healthcare workers with this. And what is happening right now, there's a lot of training on respectful maternity care. Why? This was there before, and we all learn all things, but this also helps with accountability and improved work environment. And I hear what my colleague mentioned. In public health facilities, sometimes you find is that it's one nurse and 20 others who are all in labor. And so it's more of advocating with the leadership at the subnational level, national level, just to have additional healthcare workers to come in to be able to be employed, and or even help within the maternity setup. Because for any person, if one is overwhelmed, sometimes they may not be able to act in their best of behavior towards a patient. And yeah, those are some of the things. So what is happening at policy level? There's lots of policies and guidelines. I can speak for my country towards, we already have a guideline on respectful maternity care. There is a lot of community engagement to educate the women about their rights and what respectful care looks like, because sometimes this may be abused. One may say respectful care but want certain services that maybe the nurse may not be able to do at that time, but we know that dignity has to be there and respect. But also monitoring, as going to the healthcare facilities, having exit interviews, understanding what was the experience of the mother when they're while during antenatal clinic, while during labor and delivery, and just finding ways to improve the services that are
We are
offered.
waiting for Dr. Connie.
So basically,
okay, she's back.
those are some of the oh, sorry. Hope I didn't. Can you hear me?
You went
So
off a
basically,
bit, but we can hear you now.
yeah. So those are some of the things that are happening at a global level, but also in country on matters to do with respectful maternity care. And just as I began, a lot of this is so that we encourage mothers to want to come back to the healthcare facility and deliver in areas where, in case at home, or in case they have a complication, they come in late because they've had a complication and they were fearing to come to the healthcare facility. So thank you. I hope I've been able to more to that conversation.
Yes, absolutely. Thank you so much. There was something else that Mrs. Edwards mentioned. She mentioned how she had a group of doctors managing her case, and they would, speak among themselves, but hardly would they speak to her. So, is there a way that we can shift from a system where care is just done to women towards one that care is done with them, because she said that many times she didn't know what was going on or what they were doing. So is there a way that, this legal frameworks as described by Nurse Korede can be expanded in such a way that it emphasizes respectful maternal care and also emphasizes adequate information sharing? There's this practice that I don't know if it happens in Kenya, but I know that many private hospitals, for instance, if a woman goes to the hospital and they say, oh, these are your routine drugs, they just put those drugs in sachets in this transparent little medication bags. They don't label the bags, and they just say these are your drugs. Many times they don't tell patients the name of medications. Maybe they are afraid, or I'm not sure why, but these things just happen. So, how do we ensure a shift, not just to inculcate that respectful care, but to also ensure that care is done with women? So if a woman, for instance, as Mrs. Ladju has described, that, oh, okay, this is what we found, this is what we want to do, these are the things you might expect, like care done with patients, and also balancing it with what Mrs. Binuyo has mentioned, that many of these healthcare professionals are overworked. You have so many people to deal with, so it might be difficult to balance both. There may be alternative solutions that we can use. I know that you're somebody that is into digital healthcare. Can this be a solution that, all the information that a particular patient might need is provided to them digitally, so that time they have to deal with their doctors is as productive as possible? Dr. Cornelia, can you respond to this? Dr. Cornelia, are you there?
Yes, I think my internet dropped for a minute. Can you hear me?
Yes, yes.
Okay. Yes, I hear you completely. And one thing is that health is a right, and it's a right for one to know the kind of treatment that they're receiving. It's a right for one to ask and question the kind of treatment they're receiving, and to be able even to get a second opinion if they need to. However, we also know from our culture, we are from a culture whereby the doctor is always right. We are now learning to move from that. But we are also from a culture where many times I've sat in a clinic and I've seen a patient and I asked, do you have a question? They can't ask, but because they feel if I question the doctor, they'll think that either I'm being untoward, I'm not supposed to ask. And that's where education comes in. And education, like what's happening now, education in the community with the community health promoters or community health workers, education when the mothers come to the health facility. Because when one is informed, then they can question, they can ask and say, okay, you are saying this, I did not understand. You've given me this medication. What is it for? And so bringing in that aspect, I hear you when it comes, before I just move on from that, is with education, then once one is aware of what is required, then there can be accountability. So for example, if a mom has delivered a baby and for essential newborn care, a baby is meant to get vitamin K, they're meant to get chlorhexidine for the umbilical cord, the baby is meant to get tetracycline ointment for the eyes, and birth doses of vaccines. A mother will ask, I'm being discharged, but my baby has not gotten 1, 2, 3 as we were taught during ANC. Is there a reason? But you see, because they were educated, now they know how to ask. And that also helps with accountability, because maybe if a healthcare worker forgot, they'll say, oh, yes, you are meant to get that. I'm sorry, let's do it. And they record it, because also human is to error. The digital area also helps a lot with that, because with digitization, this information can actually be shared to moms earlier, and there are different formats. During ANC, in Kenya, we have what we call the mother-to-mother groups. And with that, they have WhatsApp groups, and there is a community health promoter, and there's even a nurse on that group. And that can be a platform where information is shared within and they can actually be able to have information in their small groups from the mother to mother groups in the health facility as they work together as peer support during the time of pregnancy and even postnatally. The other thing that we can work on is even just the normal digital platforms. The thing about them sometimes is access. And that digitization comes with a good side, but also the other side is that it brings inequity, because there are areas where able to have digital systems. How do we ensure that mothers in those areas are also able to get the same services, despite them not being having digitization, being on a digital platform? The other thing, you have mothers who are not educated, so you might send them a lot to read, but they can't read. So for that mother, what do we do? So does it mean we have to have video? So we have to think through, one, all this information we have, we already know what they are, but now contextualizing them and adapting them to the population that we see. So if you're in an urban center, you know that WhatsApp groups would work very well. A digital platform where mothers can just log in depending on where they are from, and they can actually get all this information. Is there a website that's just for mothers and babies, and they can get all that is there. But now when you go to an urban informal settlements, it means you might need to have small mother groups that people can actually have information shared there. And then now when they go back to the health facility, they can easily talk to their doctor and ask questions. The other thing that, just zooming into what you're talking about, is family-centered care. That's what is happening in the healthcare facility now, in healthcare right now, meaning the doctors cannot just talk amongst themselves, but yes, they can talk and have the science, but then now come back and say the science means this, and they are able to explain this to the healthcare worker, and bringing in whether it is a partner or a spouse, but also bringing in just the family that is close family that requires to have that information, and having a family conference and discussing. And every time, for example, if a patient is in a ward, what would happen is you already see the patient, you know what is happening, but as one is being able to say, this is the medication that is being given, this is what we are treating, a lab tests were done, these are the results, this is how it looks like. And so it is a culture shift. It might not be where it's meant to be right now, but slowly by slowly, as we continue pushing these things and also educating our mothers to ask and be confident to ask, then I think in due time it will come back. It will come by. Remember, sorry, my last one, we also come from in Africa, we're a very patriarchal community.
Yes.
So many times you'll find the mother will say, or a woman will say, my husband will go and ask for me. Or if it's a young lady, my father will go and ask. They'll not ask for themselves. So also bringing matters of gender in this space, and then just empowering women to know that they can actually speak for themselves. And that's why it is not only a health issue, it's also an education issue, because when a woman is educated, then it's easier for them to have the confidence to even speak up. Research has already shown that as well. Thank you.
Thank you so much for your insights. I really loved that part where you mentioned this mother-to-mother groups in antenatal clinics, where there's a WhatsApp group, for instance, for pregnant women, so that it can support each other. I think this is really it's a beautiful idea and should be scaled across Africa. But then, of course, you said it also introduces some inequity, because what of those that don't have like an Android phone, a WhatsApp-enabled phone? There are thoughts to really reflect on there. And I like that you mentioned about education and having, confidence to ask questions. But I think Nigeria might be a bit different. And maybe some of my experience in other countries where I've lived. For instance, a medical doctor, and I've had to use care. And in instances where I asked questions, the healthcare professional look at me like, why are you asking? Why are you disturbing me? Like, that kind of thing. I think at this point, I would pause to ask Mrs. Laju Edwards, have you had that experience where you asked questions from maybe doctors or nurses, and then maybe they took it well, or maybe they didn't take it so well? I don't want to put words in your mouth. Can you just share with us, please? Sorry, you're still muted.
Thank you. What I was listening to Dr. Cornelia, She mentioned something that actually was going to spark this line of conversation. So I'm even glad that you asked. When she talked about the confidence of mothers to be able to engage in those settings. With all honesty, because of my background, I have a bit of a medical background as well. And having worked in the hospital myself for a while, uh, I always would want to ask, and as soon as you perceive that you have some sort of knowledge, you're not acting from a place of ignorance. It just seems like it's a battlefield already.
Yeah.
In fact, not marked off as oversabi, as we would say
Yes.
in that can even affect the quality of care that you will be receiving for the length of time, the entire duration, not just for that one time that you'll be showing up. And so sometimes these things affect how you want to present yourself, because it's almost as though you are at their mercy. So you want to present yourself in a way that you'll be assured of receiving the care that is even not yet enough, but at least so that I can get something out of
Yeah.
the question. So that was my experience.
This is my experience too. And I don't know if this is peculiar to the Nigerian state, but many times when we go to a new hospital, I don't introduce myself as a medical doctor. My husband will be like, tell them you're a doctor. I'm like, no, this is like the kiss of, I don't know what to call it. Because the moment they know you're a doctor, that they are like, oh, this is another of Asabi. So they are like already on the defensive. I don't know if that's the experience in other clients. Dr. Cornelia, do you want to weigh in on this?
I hear you. It happens, and but the more I hear you, the more I understand why. I hope you can hear me.
Yes, yes.
Hello.
Yes, we can hear you, doctor.
Okay. The more I hear you, the more I understand why the respectful maternity care guidelines were actually set up. Why? Because based on the experiences you're sharing, and truth, it's not only unique to you. I can also tell you in my country, I was giving you examples where you hear a mother being called based on their diagnosis from the other side. They're not even those things happen. And from a healthcare perspective, we are sorry about that, and that's why these things are happening, for us to change and make it better. And slowly by slowly, I think it will change. Definitely it will change from different aspects. A culture is very difficult to change. An attitude, it means we need to bring in social behavior change of attitude, change of mind. If someone has been shouting at clients for 20 years, one training will not make them stop. But slowly by slowly, being accountable, so that's why we have exit interviews and looking at what we call patient experience. And if the patient, it's anonymous, and the patient would talk about, this is what I face, so that when we go back and we have discussions and look at reviews of how many patients came in, what were their complaints, and we actually have self-reflective sessions and say, how can we make it better? Because as human beings, deep within, we're not out to make other people's life hard. No one wakes up in the morning just to be mean. But because some of these are cultures that have been inculcated, it takes time to change. So it means a lot of self-awareness, self-reflection, and that's why it starts from a health facility. You'll actually, even in Nigeria, I believe, there are health facilities where many mothers want to go and they say we are treated well there. And health facilities where mothers are treated well, mothers don't want to go. I've had the privilege of sitting at national level in my country, and even being able to go to subnational levels and districts. Can you hear me? Oh no. Can you hear me? Okay. So being able to go to subnational levels and go to hospitals. And when we speak to mothers, sometimes a mother will say, you find the hospital has so many moms and they're in the same vicinity. And you're wondering, why are all these mothers coming to this hospital and they're not going to a different one? That is maybe 2 or 3 kilometers away.
Based on the things that you have shared with us,
Can
can
you hear me?
you? Oh, yes, we can hear you now.
I hope so. So I'm so sorry. I think the internet.
Yeah,
Ah,
it's okay.
yeah. So as I was mentioning, usually for mother care, it really you might find a hospital where many women go to because they are treated well, yet another hospital that is just nearby, women don't go there because they're not treated well. So you might, even in Nigeria, I believe that is there. And so it's more of finding hospitals that are doing well and using them as best practices, and they're able to also go support other hospitals around them and just show that this is possible. And those are some of the things we are doing in the country. Thank you. Sorry, I think you
Thank
missed some
you
of my.
so much, Doctor. Apparently, it was my network. The others could hear you well. Sorry. Okay, so Mrs. Laju Edwards, as we start to round off this very insightful conversation, I would, let's say you're face to face with the president and you're like, okay, I'm a voice for moms and I want to advocate for better health care delivery so that women don't refuse to go to the hospitals when they need to. And this is one of the strategies for reducing maternal mortality. So, what two, three things would you say to the president to implement to ensure that women, especially, have better healthcare based experiences?
From the much that I have gathered, thank you so much. From the much that I have gathered from healthcare professionals who are here as well, I think I've come to a place of better understanding that, like Dr. Cornelia said, no one wakes up in the morning hoping to give someone else a Bible. I think the burden on healthcare professionals can be reduced so that they can be in a better place to help and administer care as they are trained to. And then there's also the place of bridging the gap between the healthcare providers and the patients or clients in terms of providing the necessary tools, equipment, and all that will be needed, environment as well, because I think sometimes some of them are working in places where they are not even comfortable, and there are not even enough equipment or facilities there, as it were, to administer the kind of care that they would want to, and they're just really frustrated. So I think that if all of those things are put in place, whilst ensuring that the patients get the adequate information digitally or however it can be done, like you mentioned, where if possible, I envision situations or cases where a doctor has your case file, has all the information that he needs to attend to you. And whilst he's attending to you, you see whatever it is that he's saying or doing being displayed to you in front of his screen. You are getting better explanation to terms that you are not even so familiar with. I just feel like it will be better. The conversation will be better. The understanding will be better. And while everything cannot be 100%, but at least if these things can be improved to some extent, to make everything better. So I would really want to say that um, on the part of the healthcare professionals and even on the part of the clients or patients, there should be a bridge. The gap shouldn't be so wide.
Hmm.
Bring everybody together so that we can receive the care that is due.
Thank you so much for that very thoughtful submission. I hear you really, to use Dr. Connie's words. I really love that phrase. I hear you. It's really important to bridge the gap between providers and the service users and also to reduce the burden on the healthcare providers to improve their working conditions. Many times we're talking about healthcare safety, but
I mean workplace safety, but people don't consider this for healthcare professionals as well. This is really, really important. Thank you so much, Mrs. Lajred, for sharing your story that has packed up so many questions. There are still many questions that if we keep going, the time will not be enough, but I think we'll just wrap it there. Thank you once again.
Welcome.
Nurse Korede,
Mm.
thank you so much. Nurse Korede, can you give some closing remarks? You know, you were talking about the respectful legal framework. Can you um, give your closing thoughts regarding this?
So
Nurse
bear with
Korede, are
me.
you
I'm
there?
just going to.
Okay.
Can you hear me? I
Yes,
apologize for my background noise. I do apologize. I'm
it's
in
okay.
transit. Yeah. I'm going to turn off my camera so you don't see moving subjects and all that. So let me just
Okay.
turn that off so you know that's the reason. Yes. Okay. So um, I've really, I'm borrowing the language, Dr. Cornelius' language. I hear all of the conversations that's been going on, and I acknowledge that practicing healthcare from place to place is really different, and the challenges are they're tailor-made to the area. Let me put it that way. It's very peculiar challenges, so it's not the same throughout. So having acknowledged that, I I will stand on the fact that I believe that human beings can change. We
Mm,
can ensure behavioral change across healthcare, wherever it is in the world, wherever it is delivered in the world. There should be certain levels of expectations. There should be certain levels of expectations that we should have. Sorry, one second. The noise and all of that. So there should be certain levels of expectations, especially in very emotional situations like childbirth, maternity, and women healthcare in general. It's a very sensitive topic, and we could never finish it in one day. Like I said, if we look at those legal frameworks and the design of it, it not only protects the patient, it protects yourself as a practitioner. Like Dr. Cornelia said, if a patient is able to ask the question and say, "Oh, you have forgotten to do so and so," they are helping you as a practitioner to not make an error. So if you see it from that angle, I think we all will be more open and welcome to correction and to transparency in healthcare and to communicating appropriately and to shared decision making between yourself and the patient. Okay, these are the options. What do you think suits your scenario? Let's make a decision. We agree on that on that decision, and then we can implement it. The patient feels like they're a part of the journey of their own healthcare journey and not
mm.
ostracized from the whole experience altogether, which can leave a really bitter taste, on people and not wanting to seek healthcare. So I just feel like that's important to put out there so that, we all can carry these into our practice going forward. Thank you.
Thank you so much, Nurse Korede. That was really insightful. And I am really glad that we are all on the same page, as it were, with Mrs. Laju Edwards in terms of, practicing, engaging healthcare delivery that involves the service users. So before I go to Dr. Cornelia, can Mrs. Binuyo, I don't know if you're still here, can you weigh in and give your closing remarks?
Thank you so much. I'm still here. I'm still with you.
Thank you.
Uh, After I hear what Dr. Colleen has said, and it has really shed a broad light into our discussion so far. So, from my end, I will just say both the healthcare workers and the patients, both of us still need to guide ourselves That is, I'll still borrow the word bridge, as in filling the gaps. When there is good communication between the patient and the healthcare system, the healthcare workers, I don't think there will be much problem. At the same time, we need to educate our patient too, to let them really know what actually is being expected of them. If they are not clear with anything, they are free to ask questions. When you educate a patient on what and what, especially we start from the ANC department, when those ones have been educated on the part of women that this is what you are being expected after you deliver, these are the things you should do, these are the things you are being expected. Like you were talking about the routine drugs given to people. On a normal day, when a patient is being given any drugs and they are not cleared with such kind of drugs, they have the right to ask questions that what is this drug meant for? How am I going to use it? But you can only give out what you have. When a patient is not being educated in that part, they believe that all in all, whatever anybody tells them, they will go along with it, which those aspects has really caused a lot of havoc. So on the part of patients, they need to be educated. On the part of health workers too, we need to be educated. At least collaborations among ourselves, and at the same time, seminars to carry each and every one of us along. Because you see, this, especially in Nigeria, you see, when you are even an healthcare worker and you know your right, I don't know if you have been in that shoe, asking a nurse that, sorry, auntie, what kind of injection do you want to give me? They'll be like, what is wrong with this patient? Are you the one that is going to teach me? But at the same time, it's the right of a patient. So when an health worker too is being educated and the right of a patient is actually ringing in their memory that these are their rights. So when a patient is asking you such kind of questions, I don't think you should be offended. So both of us, we need to balance the equation. As is filling the gap, as my colleagues has already said, and at the same time educating ourselves the more, sharing more burdens on the head of the health workers. So those are the aspects. And at the same time, people finding themselves, we see that the practice in Nigeria is quite different from other countries. But all above all, we still have similar challenges, especially if you're an health worker. If you're an health worker and you are in a system, the first thing you look at when you get there is their negativity. That's the first thing you notice, because you are in that system. And so when we are not mindful of the way we talk, and we end up not getting the better results. So I think on our part, we should be educated. On the part of the patient, we should also educate them. That will balance the equation. Thank you so much.
Thank you so much, Ma. We are grateful for your submissions. I believe that a bit of the discussions today have been fairly lopsided. We've really looked at how healthcare professionals and healthcare facilities need to change. But she brought in this dynamic where we also need to educate service users on expectations. In Nigeria, especially, we've had instances where patients or their relatives will beat up nurses or doctors. In fact, some have been beaten into a coma or to the point of death, which is not acceptable. So these are things that they need to be educated on, that these are not acceptable. These are how you should comport yourself towards service providers, and these are the things that you also can expect them to give to you. So finally, Dr. Cornelia, can you give your final submission as we weave all the conversations together?
Thank you so much, Dr. Bisola, and thank you to everyone else who has been in the call. What comes to me is patient-centered. Having care that the patient is at the center, that will be easier to have those conversations and have communication if we think of the patient come first. So really working towards patient-centered care. but also remembering and showing grace to healthcare workers. Anyone who has been to a medical school or a nursing school, I don't know if anyone had a communication class. Most of the time it was about the science of a disease and the medication to be given and all that. Maybe it's different in Nigeria, but I know we once had to have a communication class for healthcare workers, like for nurses in a specific health facility, because of the challenges that the patients and the that. And so showing grace, and as the previous speaker mentioned, having education sessions just to help healthcare workers know how to communicate. The other thing is working together wherever we are in. I don't know if hospitals in Nigeria have a patient service charter. Every hospital actually put on the wall. In Kenya, we have that. And that actually shows what are the rights of the patients, what are the expectations, what are available at that hospital, what time it would take if they have to go for these services. And that is very clearly put out for the patients to know, so that in case that things don't go in that direction, they're able to ask, but also it helps to manage expectations depending on the healthcare facility that is there, because they should also be respecting both sides. But finally, just saying that respectful maternity care is not just about saving lives. It's ensuring that women are safe, they're valued, they're empowered throughout their maternity journey. And this is so important because it builds trust between the women and the health systems. It helps improve outcomes. For most of our African countries, we're working to reduce maternal mortality, to reduce infant, neonatal, and even under 5 mortality. If there's no respectful maternity care, some of these patients will not come and seek care, and will continue having very high mortality rates. And really, it upholds the fundamental human rights and even professional ethics on both sides. And it helps us ensure that women and children have a wonderful experience as they seek care, and it also reduces the fear and trauma or any mistreatment that happens within the healthcare facility. So really just working around that and really looking at towards respectful maternity care, and even as a child after delivery, just having a family-centered approach, which also brings in the issue of respect within the healthcare facility. I'd mentioned the things that are there. Communication is there, autonomy is there, dignity, lack of discrimination, and all those other things. So just being able to bring that in. Yeah, so that's where I'd finish up. And thank you so much for having me in this conversation. You're on mute.
Sorry. I said thank you so much for the insightful session that we've had. I really still have so many questions, but we have to end it here. Maybe would have another episode where we can really dive into many of these matters. But until then, I want to say thank you. Thank you so much to Mrs. Laju Edwards and Dr. Cornelia, our guest speakers. And thank you so much for our, I would say, associate panelists, Nurse Korede Enyo, oh, sorry, Ipaye, Nurse Korede Ipaye, and Mrs. Binuyo, Nurse Binuyo. Thank you so much. We appreciate your opinions, the discussions, and the insightful submission. So at this point, I think we have about 7 minutes. So I would say if anyone has any question or contributions, please, this is the time to ask your questions or give your contributions before we go. You can put them in the chat or you can unmute and speak. If anyone from the audience has questions or contributions, please put in the chat or mute.
Maybe Dr. Bisola, I can say something before you finish up.
Yes, please go ahead.
Just to thank you for setting up this session. I think I've also learned a lot from it. It's really beautiful to hear what people are saying, what mothers are saying, because you might be thinking we have a very beautiful system and things are working, but things on the ground are different. Mothers are feeling a different kind of way about the kind of services that they receive. So thank you very much for bringing this up, and I hope can continue and even get to a bigger audience so that we can have more reach and even more education out there. So thank you for having me. And again, my sincere apologies for logging late. Thank you.
No worries at all. Thank you so much, Dr. Ochola. So I think we'll be ending the Thank you so much for everyone who has joined. Once again, this is the Maternal and Child Health Dialogue series under the auspices of FIRAT. FIRAT is Foresight Institute of Research and Translation in Rwanda. There's also a Nigerian office. Please stay engaged with our trainings, our offering. Sorry, this is MNCH series, and the scene, the child is giving a bit of background noise. I apologize for that. So please stay connected with us. We have a website, firat.rw. You can check out the website to get our offerings and other programs coming from FIRAT. We have the Nurses Diary, which I believe nurses here will be interested in. We also have the upcoming mental health series. So please just connect with us on firat.rw to see more of our offerings, and you can also subscribe so that you can get emails on when we have other programs that are coming out of FIRAT. So at this point, I say thank you once again to everyone, especially Dr. Laju, Dr. Ochola, Mrs. Binuyo, and Mrs. Upai. Thank you so much for joining us, and thank you to everyone. I wish you a lovely Saturday. Have an enjoyable one. Stay healthy, stay safe. Until the next time. Bye.
Bye-bye.
Thanks. Bye bye.
Thank you. Bye.